If I could ask everyone to please be seated. Good morning. In the words of my friend, colleague, partner, and co-producer, Peggy Clark, Spotlight Health, here we are. And we're not quite finished yet. I feel that I've already had a chance to meet and talk with so many of you over the past few incredible days, but if I've missed anyone, my apologies. Allow me to introduce myself now. I am Ruth Katz, the very proud director of the Health Medicine and Society program at the Aspen Institute. Thank you. In just a moment, I'll be telling you about the incredibly amazing individuals who will close out the second annual Spotlight Health. But first, I'd like to thank every one of you, every single one of you, for being here, for being passionate listeners, creative thinkers, riveting speakers, probing moderators, for your willingness to drive deep and the enthusiasm with which all of you engaged. Every session ended while there were still many hands up with questions and comments, and I noticed afterwards that the speakers were always surrounded by audience members who wanted to continue the conversation. I also want to thank again our underwriters, without whom none of this would have been possible. And let me, of course, offer a special note of gratitude to The Atlantic, which co-presents this event with the Aspen Institute. Equally important, a big shout out to all of the people who did the legwork necessary to put Spotlight Health together. To Britta Stevenson, to the incredible staff at the Aspen Institute's Health Medicine and Society program and its sister program, Global Health and Development, Kitty Boone and the amazing Institute folks based here at Aspen, and the dozens and dozens of interns and volunteers who lent a hand. Spotlight Health simply could not have happened without them, and I ask you to show your appreciation as well. And lastly, our eternal thanks to the sun gods. To the eternal sun gods, once again graced us with spectacular weather in this spectacular setting. It's really hard to beat, I'm sure you agree. Well, we covered the waterfront, didn't we? Nanotechnology and novel cures, reproductive health and mortality. In other words, the beginning of life and the end, equity and the ethical imperative of taking on climate change, good cooking, bad studies, and the list of topics go on and on. Still, we are often asked, what comes out of convenings such as these? How do we measure our own success? What happens when the last business cards are exchanged and the applause dies down? We'll probably never learn about all the links that were made, the many light bulbs that went off, the projects launched or replicated by folks who were inspired here. But we certainly know that happens. And I want to take a moment to just give you a few examples that I experienced firsthand. We, as you probably know, developed a late-breaking session to explore the controversies around a new drug that some call the Viagra for women. If you missed it, it was pretty interesting. But to make a long story short, one of the physician presenters started preparing for his talk and realized the drug might be of interest to his patient population, women with cancer. So he picked up the phone to call the drug manufacturer and propose a clinical trial. Within 24 hours, they had reached agreement to set one up. And Spotlight Health hadn't even begun yet. Regardless of the trial's outcome, potentially thousands, even tens of thousands of women will benefit from this work. Another bit of synergy, this occurred just last evening, I learned about it, when two faculty members from Children's National, one a palliative care physician, the other a technology expert, crossed paths at Spotlight Health for the first time. Even though they worked in the same institution, they had never met until attending one of our espresso sessions. Now they are committed to partnering on projects together back in Washington. That's what Spotlight Health is all about, birthing connections that endure and foster change. Another tool for doing just that is our Aspen Incubator Ideas, a new experimental concept for Spotlight Health 2015. This year, a day before the festival opened, we brought together a very, very smart group of people to brainstorm ideas for providing last-mile care to populations that are the hardest to reach. The group presented the results of their thinking at one of our Spotlight sessions and are now eager to get home to start changing practice. I understand money has even been put on the table already. And again, all of that before we spread out to the four corners of the world and get back to work. Just imagine how much more activity, how many more collaborations will be hatched in the months and years ahead. But finally, I want to tell you about something truly extraordinary that happened yesterday. I know many of you came to the inaugural Aspen Ideas Award presentation, where 5 finalists described great ideas designed to have broad reach and lasting impact. Every one of them was impressive. In fact, during the Q&A session that followed, an audience member asked why all of the finalists couldn't receive an award. The audience chuckled, but everyone assumed that there would be only one winner. And indeed, the judges awarded the $25,000 prize to Kapano Mubaso, a Spotlight Health scholar. Kapano's proposal, called Ona Mototo Lako, or See Your Baby, is designed to improve prenatal care by expanding access to fetal sonograms. Quite possibly, the money will jumpstart a broader initiative to bring down infant mortality rates in remote regions of low and middle income countries. Kapano got a room full of cheers, and the session ended. I'm still stunned about what happened next. Less than 30 minutes later, an anonymous donor got in touch with Aspen staff and offered to award $5,000 apiece to all the runner-ups. That means funding for Peter Drobak to train entrepreneurial health leaders in Ebola-ravaged West Africa, for Rubaiyat Khan to connect pharmacists remotely to physicians in Bangladesh, for Abraham Verghese to reduce errors in bedside care in the United States, and for Jocelyn Wyatt to expand a disruptive startup in the Democratic Republic of Congo. Not bad for Not bad for 2.5 days of conversations, presentations, and dialogue, truly. I could go on, but it is now time to introduce the moderators on our final panel of Spotlight Health 2015. David Leonhardt will be interviewing Garth Graham, president of the Aetna Foundation and an associate professor of medicine at the University of Connecticut. David is the managing editor of the Upshot, a New York Times website that covers politics and policy. He was previously the paper's Washington bureau chief and an economics columnist. Peggy Clark will be interviewing Phumzile Mlambo-Ngcuka. I know I didn't get it right, but you promised me it was close enough. She is Undersecretary General of the United Nations and Executive Director of UN Women. Peggy is Vice President of Policy Programs at the Aspen Institute and Executive Director of its Global Health Program, and you already know her as one of the real powerhouses bringing Spotlight Health to life. And last, but certainly not least, Steve Clemons will be interviewing Vivek Murthy, the U.S. Surgeon General. Steve is Washington editor-at-large for The Atlantic and the National Journal, and writes frequently about politics and foreign affairs for a number of other media outlets. Joining Steve as a very, very special guest interviewer is none other than Elmo. And Elmo, of course, needs no further introduction. Again, my thanks to all of you for being here. We very much look forward to seeing you back here again for Spotlight Health 2016. David, it's all yours. Thank you all very much.
Thank you, David.
Thank you so much. Good morning, everybody. So Garth has had a fascinating career going back and forth between being a practicing doctor and in policy. You can read more about it in your program. We're going to dive right in.
Yeah, please.
So I think the notion of inequality is now a familiar topic for a lot of people, a distressingly familiar topic. But when we hear inequality, we think about economics. We think about wealth. We think about income. I think less familiar is just how much inequality there has been in health and how much growing inequality. That all groups are somewhat healthier than they were 50 years ago, but the gains at the top have been huge. And they've been much, much less at the bottom. Can you help give us a frame to think about health inequality?
Sure. And, I think about this both from a clinical level and also kind of the population health level. So if we look at statistics across our country, folks from minority backgrounds, African Americans, Hispanic, Asian Americans, live a lot less in this country compared to the rest of the general population. They have a higher incidence of things like heart disease, diabetes, et cetera. But over the years, as I've kind of struggled with this question, it's actually less a question about race and ethnicity and a lot to do with geography. And the thing that I actually learned from really studying a lot of the data from RWJ and others in terms of place matters is really your zip code matters a lot more than your genetic code. And that's pretty powerful when you think about it. And let me give you an example that really kind of strikes home for me. This was some data that a group did looking at life expectancy in Boston. And what they did was they looked at one zip code in Roxbury where people lived to about 58 years old, and they compared that to another zip code in Back Bay where people lived to around 91 years. That's about a 30-year life expectancy. So what does that mean? 58 was where we as a country were in about 1915, 1916. And then you look at people who then are living in 2015 compared to people who are about 100 years behind. 100 years when you think about it. And so right now, and those people are, a couple stops away on a train station, a couple, it's not huge distances. And so you can really go from one train stop to the next and be in a totally different world. And that's how people are living in our country.
And you can think about it either in terms of time or geography.
That's right.
If you think about 58 or mid-60s, that's a life expectancy of a third world country.
That's right.
Right here in the United States.
Yeah.
I think, so there are obvious sources of this discrepancy, right? There's homicide. Fortunately, it's declining, but there's HIV. One of the things, I recently looked at some mortality tables, and one of the things that I found really so worrisome and stark was in every cause of death, almost every cause of death, 8 or 9 out of 10, there is a real gap between whites and African Americans.
That's right.
Whether it's lung disease, whether it's heart disease, whether it's accidents, at every stage. What explains that? That suggests that it really is a deep problem. It's not just our healthcare system.
Yeah, and I'll tell you that David Satcher, our former Surgeon General, published some data on this a couple of years ago. What he showed was that if we were to reduce that gap between African Americans and the rest of the general population, we'd save around 83,000 lives a year. 83,000 lives a year, right? And so, when Peggy came to me to talk about inequities, I had to tell her that these are things that communities have been experiencing for a long time in terms of feeling disenfranchised and all the things that go along with that. And it's important that we here are able to kind of lift up our voice in terms of what we can do to help. But you ask about kind of what are the driving factors behind a lot of this. Really, it's not even about healthcare. A lot of times it's about the social inequities, education, transportation, and all these different things that make people feel socially isolated. Let me take your example and tie this into even a broader discussion. Freddie Gray, the unfortunate young gentleman in Baltimore, lived in a place called Gilmore Court. The life expectancy in Gilmore Court is about similar to that of Kazakhstan. And so when you think about the things that we see on TV that get us all excited and erupted, we're like, what's going on in these communities we didn't know? We should all know, because people are living in either the past or in a totally different reality than the rest of us. And it's about how do we all come together, not when there are crises or not when there are riots or other challenges, but how do we have this at the forefront of our generic consciousness?
So it seems to me that often in public discussion, when we talk about health, we drift very quickly to health care.
That's right.
And health care is really important. You've devoted your life to it. A lot of people here have. I've spent a lot of time writing about it. But health care is not the main driver of health, right? And it seems to me it's important when we're talking about health disparities to start there. How do you think about the most important drivers of health that are not health care?
Yeah, and you know, there is, again, going back to kind of the concept of data, there's a lot of data to show that healthcare is probably sometimes even the least important thing in terms of an actual health and health outcomes around population. And I'm going to be very personal in this when I even think about the story, and I was telling this story at one of our earlier sessions. You know, I'm a cardiologist by training, and years ago we had this patient that kept coming back with heart attacks. He kept coming back, and we'd put in another stent, and we'd give him the best technology that mankind could. And, you know, we'd always wonder, we'd be like, why isn't he taking his medication? And, you know, we would think about him as a non-compliant patient and all the labels we give.
Where was this?
This was when I was in Baltimore.
In Baltimore.
And then I was actually going to dinner with my soon-to-be wife, and then I saw him on the street begging for money. And then it kind of occurred to me the reality, right? So we were treating the kind of the pinnacle of his problems in terms of heart disease, but he didn't have a place to live, he didn't have all these other things. And so again, going back to this concept of healthcare, really the real health outcomes in terms of the things that we need to work together on is how do we break down silos in terms of education and all the other kinds of things that offer opportunities to people to bring them into 2015.
So amidst all these worrisome trends, this gap, this growing gap, either from your perch at the Aetna Foundation or from your work as a doctor or just as a citizen, what are some of the most encouraging things you've seen?
Yeah.
What are, whether it's one program, two programs, whether it's trends, what seems to actually be getting at some of these gaps in a way that if more people knew about, there might be a way to spread those gains across a larger group of people?
I'm going to give two examples. One that we support, as well as another kind of really interesting example that I'm seeing burgeoning out of the Robert Wood Johnson Foundation. So because of these experiences, we're very much in terms of target local funding. So how do we break down silos in terms of local opportunities for people to have access to fresh fruits and vegetables? And that's kind of one of the big things that we do in terms of trying to do this. And we see a lot, particularly in Detroit, where people are allowing folks, one of our grantees is allowing folks to use supplemental nutrition, the SNAP program, to be able to buy and access farmers markets kinds of foods. And we like to see things like that.
And SNAP is basically food stamps,
That's
right?
exactly right. I'm sorry, I should have said that. Right. So, you know, how do you break down that barrier between that food financing to get people the best kinds of food they can get? But I'll tell you another example.
Can I ask one question
Please.
about that first? So is the issue that SNAP as it is doesn't let people use it to buy it? That can't be the case. Or is it,
No, it's just kind of normally the mechanism that which people utilize SNAP and the locations in which some of these kinds of things would be available are not always co-located best together. So sometimes you have to bring these opportunities in terms of fresh fruits and vegetables closer to communities, closer to urban communities, so that people can then be able to have access.
So that the fruits and vegetables are in front of them.
That's
so they
exactly
can actually
right.
buy
Yeah,
them.
yeah.
And one more thing on that, we won't lose track of the second thing. What about the cost issue? I mean, it seems to me that one of the issues is, what does a hamburger cost at McDonald's? Is it 79 cents? I don't think it's a lot of money. How much of a problem is the fact that bad food is sometimes cheaper than food that's good for you?
Well, you know, I think that is one potential challenge. I will say that I think sometimes when we articulate the challenges, we underestimate the power that people care about their own health. And so, for instance, one of our approaches is to say, you know, how do you empower people in low-income communities to have all the information to make the best decisions certainly when things are co-located together? And so what I think through in this is don't underestimate the passion for people, particularly in low-income communities, to care about their own health and to seek out things to make them healthier. But I was going to give another example that I just heard that was really kind of heartening to me, and this is how folks need to kind of break down silos. And this looks towards some of the things that Robert Wood Johnson has been doing in terms of engaging chambers of commerce and businesses and folks across those lines to kind of bring all the folks to the table. And you recently wrote an article about the 1.5 million lives that were lost in terms of African American men. And I remember where I was when I read that article.
Thank you.
And I was really excited. And let me tell you why. And this goes back to kind of the tying into what I was saying about what RWJ is doing. For far too long, we have ascribed these problems as African American problems, Hispanic problems, poor people's problems, doctors' problems, et cetera. And then when we see communities erupt, we realize that they're American problems, and then we scramble to think, what should we be doing? And so these problems in terms of the challenge we're talking about, life expectancies in our communities, they are American problems, problems for businesses, problems for educators, problems for doctors, problems for reporters, and we all need to keep people engaged. And it's about how do we ignite that fire to have people understand that these are real problems. And I'll say the last thing is, I actually believe that these are the defining problems of our times. If you look at when any of these issues about inequities come up, we are glued to our television for the moments that they happen because we see something getting burned down and we're enamored. But there are people suffering behind these inequities right now every day. And they've been suffering for decades in these communities. So we don't need those inflammatory images to engage us. We should be engaged because we know that there are communities that are suffering and living so many years behind.
Have I figured out the microphone? Excellent. Thank you for bringing up the article. So just to give folks a little bit more detail on that, when you combine the number of African-American men who are incarcerated, the number of African-American men who have died prematurely, and then a bunch of other categories, people living on the margins of society, not counted by the census, there is really an enormous gap between the number of African-American women we have living in our society out in communities and the number of African-American men. In white communities, there is essentially no gap. There are roughly as many women as there are men. In African-American communities, there's an enormous gap on the order of 10 to 15%. And you just think about, first of all, you think about those lives lost or those people in prison, and then you also think about the knock-on effects of that, and you think about what it is like for a community to have such an enormous gender imbalance. It helps you understand things like family structure issues and stuff like that.
Right. And what you did in the article, I'm not going to pat you on the back just because you're here. But he's here, so why not? And I'll say this, and I've said this before, it's important that people like you, just like it's important that people in leadership positions here who have other responsibilities get engaged in these discussions. And that's why, again, when Peggy kind of said, Aspen was going to make inequity a priority here, I was like, I got to be there. Because it's about how to engage leaders at all sectors. But what you did was you brought the argument that people have been living a long time. People know that minority men are missing in many communities. They feel it. But they don't know if other people know that. And they don't understand that. They need to know that it's important to you, it's important to us, that we lift up the plight of African-American men in our community.
Thank you again. The zip code point I think is a really important point, and I think it's worth folks thinking about in all kinds of ways. It actually applies to so many different segments of society. The fact that if you know someone's zip code, the odds are really high that you know an enormous amount about their lives, that you know about their income, that you know about their education, that you know about their health. And on the one hand, it's deeply depressing because it's a sign of the amount of inequality that we have and the amount of residential segregation we have, not just racial, but also economic. On the other hand, it strikes me that it provides a roadmap to solving some of these problems. And to make a quick analogy, one of the things that I've written a lot about is the lack of economic diversity at colleges, at top colleges that have the most resources where kids graduate. And sometimes the colleges say, well, how do we know which of these kids are actually the low-income kids? And the answer is you need usually one statistic. They're 5-digit zip code.
That's right. That's exactly right.
And so can you give us a sense from the standpoint of health, not health care, what that means in terms of diverting resources more toward the places where they're most needed? What mistake are we making right now that doesn't adequately recognize the amount that zip code drives people's lives?
Right. So so your analogy is great, and I'm going to tie this to what I said earlier in terms of the mistakes I made in clinical care and thinking about a particular patient. What we do is we divert our resources, our technology, our understandings of all these exciting things like genes and all these new things that we can deploy, MRIs, the fancier kinds of MRIs and all those things. We deploy them to all the people who already are healthy. And are healthier or who have access, or the people who can access these things better. And what we really need to do is to drive down to that, and that's part of our funding strategy, is to drive down in terms of the zip codes that have the greatest needs and create the most basic opportunities, again, for people to have healthier diet, have more economic opportunities, and to be able, again, to understand the importance of all the other things that they can do to make themselves healthier. So we should be doing hotspotting, and this is a Jeff Brenner term. Jeff Brenner's done some great work on this concept of hotspotting. We should be doing more hotspotting and more diversion of our resources to those communities as opposed to the worried well. I often use the example when I think about my own family. Is my wife's a psychiatrist, love her to death, extremely healthy, and she has all the gadgets and technologies. And she's the person who needs it the least. because beside her beauty, she's pretty healthy. And so I think that all of the kinds of things that people like her have access to is we need to start diverting that more towards some of the communities and zip codes we've been talking about.
How do we do that from a persuasion effect? Meaning, how do we say to people, hey, you've got enough? I mean, I think most people, it's the human instinct is, you know what, actually, I'd like to be a little healthier, right? And how do you make that case to people in a way that actually has an effect?
And the weird thing about health is, for me to do something in a community, I don't need to take away something from you. So I don't need to make your life, truncate a little bit. I don't need to take 2 years from life expectancy to give it to somebody over here. All I need to do is to be thoughtful, right? So it's less. It's not even income redistribution. It's actually just decreasing health equities by being thoughtful. And here's what I would say in a very practical way we need to do. Again, we need to look at those communities that are the most disenfranchised and figure out collectively how we can engage the mayors, education, healthcare folks, the funders like ourselves and others, and then help to kind of drive down to make, again, sure that people have access to things that are emphasize preventative health, and also be able to have access to healthcare. And it doesn't take away anything from you or me or my wife when we do that, because what we're really doing is just making sure that we have an equitable distribution of resources.
One thing that strikes me about that is that seems particularly more plausible because of how much money we waste in high-end healthcare, right? It would be one thing if all of the most expensive, most invasive treatment was actually delivering a lot of benefits to people.
Right.
But in fact, one of the things we know is that a lot of those treatments don't actually deliver much, if any, benefits. And so there's a way in which this whole debate about bringing down the cost curve in healthcare, which actually has already begun to happen, there's a way in which it's directly connected to what you're talking about, right? Yep. Because if we bring down that health curve, rather than wasting a lot of money on invasive healthcare that isn't actually benefiting people, we can do more of the stuff that you're talking about.
And so again, going back to your earlier point, this is why I think we have the best opportunity in healthcare. We have overuse in all kinds of things, certainly in cardiac care, of which that's my area, but in all kinds of different areas. But I don't even know if that's all we have to do. I think all we have to do, again, is to be able to connect some of the dots locally and then make sure that, speaking again to our audience in this room, make sure that we all are aware of our own responsibilities and why we should make this a priority. And, quite frankly, as I said before, I think the whole issue of inequities, I was listening to Ashley Judd, and she said she was recoding Tony Fauci, so I would requote Ashley Judd, recoding Tony Fauci, and he said that Ebola was a disease of poverty. And that really the concept of inequity, what we saw there, really added and exploded in terms of what Ebola did. And we're seeing this every day in our communities with heart disease and all these things. But people are dying just like how people are dying from Ebola. And so it's important to understand just how defining this issue of equity is in our communities.
Yeah, I mean, in some ways, every disease is a disease of poverty.
That's right. That's right.
Yeah.
That's right.
It's also the case that for all the attention that things like pre-K have gotten for their importance for education, and pre-K is vital for education, there's a way in which high-quality pre-K is actually a health program.
Yeah, that's right.
For the kids, for the parents,
that's right.
For everyone.
That's exactly right. And it's important in terms of, I'm thinking about some ideas that came out of our Aspen incubator session and some of the good things. And again, we talked a lot about problems here, and let me segue before we end in terms of solutions. And I'll use the incubator discussions as an example. We talked a lot there about how do we create leadership, and then how do we help strengthen that leadership, as well as how do we penetrate communities with things like community health workers, technology. That's part of our shtick too, is technology, and how do we deploy technology in underserved communities. So there are solutions abound. And there are different things that we can do. And so I think as we kind of think through, as we all kind of leave here and think through all of this, one thing I would say is, again, engagement. And leadership means not just, the preacher and the African-American church caring about those communities, but you all, in terms of your own leadership positions, making sure that we look at how we distribute some of these efforts equally. So there's a lot of potential solutions out there.
And now you're not going to get off the stage without talking about yoga. Yes. If anyone knows this, Aetna is in the middle of a big mindfulness and yoga kick.
Yeah.
So tell us about your own personal yoga experience.
Oh wow! So I got to tell you, if you said to me 2 years ago that this would be something I would identify as very important, I might not have been that much of a cheerleader, but it's been great. It's been great. We also have we have a 3-year-old who tests the limits of patience on an hourly basis. And so in that concept, for me, being able to kind of just settle, understand and live in the moment, and then know that he will grow to be hopefully a successful adult one day, and not react is important. But I'll tell you one of the things I've learned as we have explored this concept of mindfulness more. It's a great potential tool, again, in many communities, underserved communities, to have people understand how to help channel and understand our own emotions. But it's also been important for us to make sure that we are, again, thoughtful of the work that we do and thoughtful of the impact that we're having.
Well, we have so many good speakers. I could listen to you all day, but we need to make room for them. Thank you so much for making time to do this.
Walter just reminded me of a really wonderful opportunity today. Penny Pritzker, Secretary of Commerce, is speaking at 2 o'clock today. So all of you that are Spotlight Health pass holders, please join us. It will be right here in Greenwald Tent. I thought Walter was going to come up and say, okay, I really got it. Women really are, the future of the world. And I really need to get up here and interview Phumzile. I know that Walter is surrounded by two really powerful women, so I actually know that is true. But it's my great honor, really, to have an opportunity to talk with a powerhouse woman. Sitting beside me is Phumzile Mlambo-Ngcuka. Phumzile is a dear friend. She's UN Undersecretary General and head of UN Women. She was appointed in August 2013 following President of Chile, Michelle Bachelet. UN Women was created in 2010. It's the first time that a UN agency was dedicated to women's issues. Phumzile's had a remarkable life. She was Deputy President of South Africa. She was Minister of Minerals and Energy. She was Deputy Minister of Trade and Industry in South Africa. She was a member of Parliament. She was an active member of the anti-apartheid movement. She also created a foundation that focuses on education for youth in South Africa, among many other things. I met Phumzile when she was head of the World YWCA, which is an important platform for women and girls all over the world. So Phumzile, let's begin. It's been an interesting year for women, 2015. It's been an interesting year. We can't help but think about Malala, the bravery of Malala, the young woman who really spoke to the importance of girls' education all over the world. We saw many of the 200 girls who were kidnapped by Boko Haram come back, all of them pregnant, which was a very deeply troubling sight. We have Hillary's candidacy on the horizon. The headlines were splashed with the Rolling Stone article that was about campus rapes and sexual violence on campus. A young woman named Emma at Columbia University is carrying around a mattress to protest against the university's lack of action for a sexual violence case that she was a victim of. So it's kind of the best of times and the worst of times. And as someone who's worked on women's issues my whole life, I can't help but ask, Phumzile, where are we with the women's movement? I am heartened by the power of your leadership at UN Women, but tell us what your mandate is and what you see right now as head of the lead agency working on women's issues.
Thank you very much, Peggy, and to everybody who's here now. Just the examples that you've picked up from a young girl, Malala, who has brought forward the issue of violence against girls and has forced many countries and member states that we work with to address the issue of safety in schools. Because going to school for a little girl doesn't have to be an act of bravery. But what has happened there is turning a tragedy into a powerful campaign that this little girl handles so well that she's now a light for many girls. So tragedy, but she's turned it around, and thankfully, there's a lot of girls who are identifying with her. Nigerian girls, actually the Chibok girls are not back, but we've been able to get back some of the girls that were abducted, because what we saw in Nigeria is really a tip of an iceberg. There are so many girls in different parts of the world where there's conflict who are abducted as we speak, who are sexual slaves. And what, on my part, frustrates me a lot is the fact that most of our counterterrorism strategies are not engendered. We haven't grasped enough that girls are part of the military doctrine of the non-state actors who are now waging war, and that in many parts of the world, it is indeed more dangerous to be a woman and a girl than to be a soldier, because girls are abducted and they are not trained and they cannot defend themselves. So it is in that space, putting together the strategies, and we're working with all the military forces of the country as UN Women to really highlight that. And then on the positive side, the fact that Hillary is running is a plus, that we've arrived at a world where a woman in this important country is able to stand up and scare a whole lot of big boys.
Thanks, Phumzile. So the secret about Phumzile going into the role at UN Women is she's been really, really shaking things up. And I think many of you probably thought, oh, you know, women's movement, you know, been there, done that. Really, haven't made any progress. But Phumzile has approached UN Women with this incredible political, strategic intensity. And she's been really shaking things up there and bringing in some totally new approaches. Tell us a little bit about what you're doing in terms of going right to heads of states, going to heads of CEOs. Tell us a little bit about your strategy at UN Women.
Okay. Well, I have decided that I'm a leader of UN Women, but I really need men. Not to create UN men, but I need men in the space to be anchored in the fight for gender equality, because women have done everything. They've been the torchbearers, they've paid the price, and we have all the problems that we still have. And one thing that we've neglected as activists of my generation is really to work with men and boys as part and parcel of the solution. So I'm investing a lot of my time in making sure that men and boys have a role to play in the fight for gender equality, because they are the pen holders in many of the decisions that we have to make. We cannot wait until we've got adequate representation of women, then we'll be able to have the decisions that we need. We need the decisions now, and if the heads of states, as it turns out to be, majority men, we need them to own this problem. So I spend my time talking to presidents of countries, not to women's ministries, because women's ministries in many countries are in any case underfunded and marginalized. So I go to the head of state and say, you have voted by people of your country, men and women. This is the situation of the women in your country. I need action on your part, because you are the most powerful person in this country. I do the same with CEOs of companies. I do the same in universities with presidents of universities in relation to what is happening to girls in many countries, including the US. So my strategy is to delegate upwards and to diversify the partners that are part of gender equality, and to make sure that our hardcore gains as the women's movement are not leading us to look downwards and to be exclusive. But I would like us to be more inclusive and to make this a mainstream issue that it is. The women's issue is not a minority issue. We cannot make an issue of more than half of the world's population to be a minority issue that just special people who must be a feminist of a particular type to be the ones that are running it. This is an issue for an average Joe, as much as it is for people who are experts on gender equality. This is an issue also of addressing issues of how we create positive masculinity and make men play that out and be role models.
So, what does that mean, positive masculinity? Tell us about some of the heads of state and some of the CEOs you've talked with and the commitments they've made in the He for She campaign.
Okay. I think positive masculinity is just about being a good father, as it is to be about a head of state who say, I will make sure that I fight on violence against women in my country. So we have a campaign called He for She, where men can register on a website to identify and to play out their commitment to gender equality. Once you've registered in our heforshe.org, you then must take specific action that drive your expression of being there for gender equality. So then I've picked on 10 countries, 10 companies, and 10 universities around the world to be my leaders and to drive the campaign forward. But as much as I'm encouraging everybody for a bottom-up approach. The 10 countries include Iceland. Iceland is the least failed state in the world, in the sense that if you look at all the right indicators in a country, they've got all of it right, especially those indicators that relate to women. So I said to them, I need you to aspire, because there's no country that has achieved gender equality with all the work that we all have done for hundreds of years. I need you to aspire to be the first country to achieve gender equality, because you're the closest. And of course, the president thought of set and said, what exactly would that mean? And I said, you have to find out, because also this has to be data-driven as well. What are the gaps in Iceland society? One of the things in Iceland is just alcohol. Men beat up women, as it happens in many countries, because of drinking. It's a country that has so many positive, but they have this problem. Unequal pay, global problem as well, just like violence against women. Poor representation of women, or maybe inadequate because they're better than many countries. And of course, unpaid care work, women being trapped at home or doing double shift, working outside the home and working at home. So they are looking at finessing the interventions, and we said, let's work on this alongside the Sustainable Development Goals, which starts in 2015 to 2030, and try and crack all of these things that's a barrier for you to becoming a country that could give us gender equality. Because for me, it's important that we have countries that aspire to really turn this around and to achieve gender equality, so that we can just demonstrate that it is possible to have a society where men and women are equal. I always say to people, in the 19th century, the world fought slavery. We have not eliminated slavery completely, but you cannot enslave people with impunity. There's recourse, and we all stand on the same side as normal people against slavery. 20th century, we fought racism, we fought apartheid in my country, and all good people of goodwill, we stood on the same side and we fought together. And we made this colonialism, racism, unacceptable, even though we still have it, but it is unacceptable. There is a lot of relaxed attitude towards gender inequality. And I want to mobilize as many of us, men, women, young, old, to be on the same side of this argument, so that it is not okay to underpay women. It is not okay to trap women in unpaid care work. It is not okay not to have access to girls' education. All of those things that are game changers in society, we must make sure that we all work as hard as we can, wherever we are, to make sure that we can make life better for women and girls.
Thank you, Phumzile. Let's talk a little bit about progress or lack of progress in this area. You mentioned unequal pay. I remember some 10 years ago, the issue of 60 cents on every dollar in the US. Certainly, as you're mentioning, Iceland is the only country that may have the chance of getting to gender equality. You and I talked a little about unconscious bias. And I have certainly felt that as we've been struggling for issues of women's rights around reproductive health and other issues. And this year, certainly in the US, I think we're looking at race in a really different way. Is there a need for us to look at sexual discrimination in a different way? Are there things that those of us in this room are not seeing about men in particular, about unconscious bias as it relates to women?
Well, privilege isn't always obvious to those who have it. If you sit as a list of men in a panel or in a board or whatever, it isn't all, and you're there because you feel you qualified to be there, and you are the leaders on top of your game. You may not see that you actually have a privilege that patriarchy bestows in every boy as soon as they are born. You don't have to ask for it as a boy and a man. You just get it. What we are trying to say is that men and boys must actively denounce that privilege. Because many of them, I think, obviously in this room, do not want to oppress anybody, do not want to have an unfair advantage. But if you don't do anything about it to change the lives for the other, then you enjoy that privilege. It becomes your unconscious bias towards other people. Mandela said, when good men do not do anything to fight for gender equality, that is conspiracy against women. So it is instilling that activism so that the good men actually play out their value system so that we can have a groundswell of the goodness that is in the good men. So that is where the whole concept of unconscious bias also comes from. We also have seen that if you are able to talk to, which I do, I go to CEOs of companies, I say, is there equal pay in your company? Nice guy? And it's usually very nice people. And he says, yeah, of course, my company tick all the good corporate governance specs. And I said, but have you really checked? And there has, in many incidents, they come back and say, you know what, I went and checked. I just don't know how it happened, but I actually have people who should not be paid what they are being paid. And thankfully, there are some that are actively trying to address that, but not enough. So what I would like to see in our lifetime, and very soon, is that we actually change that around, so that as a CEO, it is your responsibility to check how people are being paid. It's even worse for women who are at the bottom of the pyramid, which is where most women are. 50% of the women today work outside the home. 75% of the women who work outside the home are underpaid, or they're in the informal sector. They do unprotected work. They have no minimum wage. So they are working outside the home, but they're not getting the full benefit of being a worker, and they're not contributing as much as they should and can to the growth of the economies of their countries. But it takes the ones that have the powers to actually look into that and fix it. If we have a combination of heads of states, of our leaders in the university sector, in the health sector, in the political sector, actually seized with this matter and really looking at the intricate details of trying to find a solution, I really have hope that we can push significantly forward so that by the time we come to the end of the Sustainable Development Goals in 2030, we should be bending the curve of gender equality decisively downwards.
Right. Excellent, wonderful. Phumzile, one of the things that really enchanted the whole world about South Africa's struggle is the notion, and you said this, you said, we shouldn't just be fighting against, we should be fighting for. And the approach of inclusivity is such a powerful tool. Have you had a hard time using that tactic as a head of a UN agency at a time when UN agencies are often thought of as ineffective? How can you bring that message forward?
Yes and no. But first, let me just say that I know that I have to defend my organization. That if you think about, yes, there's lots of weaknesses in the UN, but if you just think at the Millennium Development Goals, if we did not have those goals, we would not know as much as we know about what pushes maternal health issues in many poor countries and what we need to do. We would not know as much as we know and act as we do about infant mortality. It has been the power of internationally agreed goals that the UN galvanized that has helped us to grasp these issues and for countries to take them serious. If you think of HIV and AIDS and the coordinated efforts that all of you as health workers were driving, but also the role that the United Nations played, if you think of girls' education, and the fact that we have increased access such that more than half of the countries have got 50-50 access, never mind that we still have dropouts and other problems. That is the power of an internationally coordinated agenda that the UN plays. And then, of course, there's a whole lot of other things that we get wrong. Humanitarian needs, if you think of just the disasters that we have in the world, if you think about the argument about climate change and where we are with that argument, so there are those things, but we have to continuously help the United Nations to be better and to be inclusive in the work that you do. And so for me, coming at UN Women, I was single-minded about working on the issue of women, not as a women's issue, but as a people's issue. And it was a bit foreign for some of my colleagues, bringing in private sector, bringing in men, that's not a great feminist. So I had to be, we have to make it happen. We would not have won apartheid in South Africa if we made it just an issue of Africans and blacks. It was an issue of everybody in society, black and white, who wanted change, and of course, also a global issue. You need international solidarity in this area, just as we have needed it in many of the areas that we have been discussing here in the last 2 days.
Excellent, Phumzile. So I can't have you leave the stage without calling your mom here with us. We had the pleasure of Phumzile's worked with her mother on education of youth, and her mom brought a whole group of about 75 young African women to Durban when we were there for the climate change talks, and we were bringing the issues of women to environment. And a conversation Phumzile and I had, I will never ever forget it. It was about sustainability. And I said, Phumzile, how are we going to bring these issues of women's health forward? You know, the environmentalists don't really see, they can't talk about population anymore. How are we going to cross these issues? And you said, the youth see it completely different. They see a world where these issues are integrated. Tell us what you see ahead that gives you hope.
Well, I think that it is very encouraging that many young people understand the fact that their rights, for instance, to services to do with family planning are just as important as their rights to education. They refuse to be made to choose, and that their full cycle in life has to be catered for. As girls or boys, as young people, as parents, and going further. So their fight, in a positive way, is about wanting it all and wanting it all now. Because you have to take care of all of these intersectionalities. A disabled person needs to have their issues attended now. They need to have their health now. They need to have their economic well-being now. And I think this comprehensive approach that I think I hear a lot when I talk to young people is, for me, a very hopeful sign, because it helps us to break the silos that sometimes we're trapped in. But also, if you think about that horizontally as well as the vertical approach, the delegating upwards and looking at the most powerful countries also to role model for everybody else is just as important, because also we look at what happens in those countries that are most visible, and we try to make sure that we make it happen for many other people, or people aspire for the same. I was telling you that I'm co-hosting an event with China in September, because I have asked China to say 20 years after Beijing, which bears your name, Excellency, we have not achieved what we wanted to achieve in Beijing. We need to rescue this agreement by having countries come up again and make new offers, game-changing interventions, which must include, for instance, reproductive health and rights, to take us forward. And we have agreed, therefore, with China. We will host this. And I've said to the president of China, you must invite your peers. This is not a conference of people who do not have power and authority. You guys hold the key. The women are standing outside the door. Open the door.
Great.
Don't
Excellent.
keep them outside knocking.
Thank
So
you.
I'm hoping that that conference will really bring in the heads of states, the heads of corporations, and they will put on the table, hopefully, some really significant ideas. And if you have some ideas to give to me so that I can give to them in the area of health, things that must really make sure that we create destiny-changing interventions that countries should be taking responsibility for, so that 2030 can look different. I don't want to sit with you here in 2030 and talk about the same things.
Exactly. Phumzile, we're with you. Thank you so much.
Greetings, everyone. Vivek, I thought we were going to start out today with some sandals and shorts. No? You know, what is it with the suit?
I didn't follow through
Yeah,
on
you're
that
an
end of the bargain.
Aspen, right? No, I mean, last night Donna Shalala was telling me that you also get a sword. Do you wear a sword as well?
I didn't bring my sword.
You didn't bring
today.
your sword.
I didn't want to scare
Do you
you
at least
off,
get to
Steve.
wear happy socks? No. No, but you are the youngest Secretary General in the history of Secretary Generals. You're the 19th of them. Surgeon General. We just had the UN up here. It was just...
I thought you were giving me a promotion.
Yeah, Surgeon General. But you're also considered one of the most controversial Surgeon Generals that we've had. And I'm interested, you know, in that, in how you feel you see your role as convincing the nation that it can be a healthier place. How do you think about your role in that? What is a healthier nation, and what kinds of tilts do you think you need to give your job? Because you haven't exactly been shy in the time you've been in office.
Well, thank you, Steve. Let me first start by telling people what the Surgeon General does, because not everybody knows. The Surgeon General's traditional responsibility has been to communicate with the public about important health matters. The additional responsibility of the Surgeon General, is equally important, is to oversee the Public Health Service Commission Corps, which is a group of 6,700 officers across the country and around the world who have dedicated themselves to public health. Now, the approach that I want to take to communicating about public health is a little bit different. I want to, number one, really modernize how we communicate, to think about what can we do beyond issuing reports and giving speeches to really reach people with the right messages at the right time. The second thing that I want to do is to work directly with community organizations, with individuals who are on the ground, to help them translate a lot of that information about health into action, which increasingly we're finding is the tough thing to do. And third, I want to make sure that we are enlarging our conception of health, taking it beyond the borders of the United States, and recognizing that in 2015, that domestic health is global health, and that what happens abroad has a direct impact on us. We saw this with Ebola. We've been talking about it with the MERS virus. We've seen it with measles. Increasingly, our ability to work with other countries to promote better public health will have an impact on our health here. And lastly, to your point about being controversial, I will say that I don't own the distinct honor of being the only controversial Surgeon General nominee. I would say that I'm in good company with C. Everett Koop and some others.
C. Everett Koop is the Surgeon General that most people remember. Then there were a lot of them that we don't tend to remember, unless you're sort of a health wonk. But what made him so special, and what about him inspires you in your role today?
Well, C. Everett Koop really is my favorite Surgeon General, and I have great memories of him when I was younger, watching him on TV, reading things that he wrote. But I will say this, that what I love about C. Everett Koop is that he was willing to say what he needed to say, even when it was difficult. He was willing to speak the truth when it was hard. And that's essential in a Surgeon General. You know, there has been controversy around my nomination for Surgeon General around a tweet that I had posted a few years ago after the Newtown shooting, where I said...
Why don't you share the tweet? Sure.
The tweet said that gun violence is a public health issue. And I said that after Newtown. I'll say it again today.
You've also talked about climate change. You've moved into a more holistic. One of the very interesting things about digging up your views and whatnot is you have a very expansive view of what the kind of health ecosystem ought to comprise of. And you've testified about climate change.
Yeah, so this is very important. We have traditionally thought about health in a fairly narrow context. We've thought of it as what hospitals do, what clinics do, what doctors and nurses do. Health is far more broad than that. When I think about the patients that I used to see in the hospital, I recognize that as much as I wanted to talk to them about changing their diet and changing their physical activity, that the truth was that the factors that were really driving what they ate and whether they worked out or not and whether they had an active lifestyle were not in the hospital, they were actually in the community. It was based on what they saw at home, what their friends were doing, what foods were available and affordable in their workplaces and in their neighborhoods. Whether they were active sometimes depended on how safe it was to actually go outside in their neighborhoods and walk. These community factors are what drive health. And so in 2015, when we are facing and grappling with the difficult question of how do we improve health across America, what we really need to think about is how do we go into communities and affect and impact factors there that are actually driving health. And what that means is that each and every one of us needs to recognize that even if we don't have health in our title, that we have a role to play in improving health, and we have to embrace that role if we want to truly create a healthier country.
You know, when C. Everett Koop was Surgeon General, there were a lot fewer pipes to reach a very large audience. Today we have bloggers, we have health blogs, we have associations, we have, you know, it's just a very, very disaggregated media market out there. But do you still need to, you know, in thinking about the job of reaching all of these communities you have to do you think you need to be a celebrity of sorts to do that?
Well, I think it depends on how you define celebrity. One thing I will say is that I believe to be an effective Surgeon General, you cannot shy away from the spotlight, that you need to be comfortable with being out there. You need to be comfortable, particularly with being out there on issues that are difficult, that are controversial, or that are not clear. And that's one thing that I intend to do as Surgeon General. But I'll also say this, that in getting out there, there's a notion that, I think a traditional notion about the Surgeon General, that the Surgeon General has to be the repository of all information and share that with the public. I don't believe that that's the case. I believe that while the Surgeon General needs to be out there talking about important health issues, that to be a truly effective Surgeon General today, that one needs to mobilize other messengers and other voices in the community to get them to speak up and to speak to the people that they can influence so that we are, as quickly as possible, helping to bring important health messages to the public.
Now, you've been working with some moms groups. Tell us about that.
I have. So during the, some of you may remember, at the end of last year, there was a measles outbreak here in the United States. And as we were thinking about how to go out to the public and get out information about measles, we decided to collaborate with a number of groups out there, including moms groups. And the group we collaborated with was called Moms Rising. We did a town hall with them with 13,000 moms, where we talked about, we took their questions about concerns they may have about the measles vaccines or other vaccines, and we addressed them head on. That kind of partnership, these are the kinds of partnerships that I want to continue to expand, because the truth is, whether it's Moms Rising, the YMCA, or other groups, each group has access to a particular part of the public, and we need to make sure that we are working together to get health messages.
You've got a great website. I want to compliment the Surgeon General website. All of you should go take a look at it. And the 4 areas, the 4 nodes, if you will, the 4 pillars, are tobacco-free living, mental and emotional well-being, healthy eating, and active living, in which you're trying to encourage everyone to sort of take more responsibility in all these areas. But I'm also interested in sort of the mental health dimension of this, because you've written that when you were practicing medicine, that no matter who was coming in with whatever ailment, you often ran into a mental health dimension behind that problem. And you've said there are 42 million Americans suffering from mental health today. So what is your strategy in that arena of trying to sort of demystify and move the needle on mental health in the United States?
So that's a great question. Mental illness is a great concern for millions of people across the country. And the truth is, whether we are suffering with mental illness or not, all of us are touched by it in some way. But let me back up for one moment, because I want to say that while there are specific areas like tobacco, mental health, violence, physical activity and nutrition, prescription drug abuse that we are focusing on, there's a larger theme that runs through all of these areas. Right. And those are 2 themes for me. One is around creating a culture of prevention in America, and the second is at making sure that we are bringing health equity to everything that we do. So those are the 2 themes that run
What does a culture of prevention mean?
So I'm so glad you asked. Right now in America, we have a culture of treatment. We invest the majority of our time, resources, and money in building hospitals, in developing new technology, and in developing new medications. These are very, very important, but we invest far less in prevention. Now, if you go into the public and you ask people, is it better to prevent an illness rather than to get it and treat it? Almost everybody will say yes. So you don't have to convince people that prevention is important. But here's what we do need to convince people of, that they have a role in making prevention work. And that's why if you are an employer who's thinking about what you can do to create a healthier community, a healthier country, you can think about, for example, the food that you're offering in the workplace, because workplaces are where people spend a third of their life or more. If you're a school, thinking about what you can do to make sure kids are healthier and creating a foundation for a life of health, you could think about how you're engaging kids in physical activity from day one, and also what food you're serving in the cafeteria and in the vending machines. If you are a faith leader, and this comes to mental health, since you asked, you can think about the messages that you are sharing on Sundays, on Friday evenings, or whenever you're engaging with your congregation. And this is one of the partnerships that we are building around mental health, is a partnership with faith communities so that we can work on removing the stigma that is still associated with mental illness, which we need to get rid of. And that prevents, while we can build better mental health systems, and we need to, while we can make them more affordable and accessible, which we need to, if people are afraid to come forward and talk about their mental illness and get help, then they won't make use of those resources, and that's what we need to address.
You know, whenever I absolutely, whenever I come to Aspen Ideas or Spotlight Health, there's so many people who have crystal balls for the future. They're talking about what the world will look like in 5 and 10 years from now, what we'll need to do. And one of the things that's woven into this Spotlight Health are some really brilliant innovators in the technology space that are looking at how do you see technology either helping or hurting some of the missions you have, either in a culture of prevention or getting more equitable health outcomes across the country.
Well, I'm very interested in technology and its applications to health. Before I was Surgeon General, I spent about 7 years working on building a technology company to improve clinical trials. And I still remain very interested and a strong believer in the promise of technology to improve health. There are benefits and risks that technology will bring to health. The net, I think it's going to be a positive for us. But technology, one of the things that it will do is give us the ability to gather information much more easily than we do now. It'll give us the ability to interpret that information, especially big data, in a way that we don't have the capacity to do right now, or didn't at least 5 years ago. But there's also a risk, which is that when you look at the internet and the ability to share information freely, that is both a blessing and a curse. And what we saw during the measles outbreak, for example, was that with just a few keystrokes, it was easy to spread rumors about the measles vaccine. And some of these rumors, many of them, were around an association between the measles vaccine and autism, which I want to be very clear, there is no proven link between that. There was one study which purported to show a link, but it was a fraudulent study. It was debunked by multiple studies afterward. But these rumors can get spread very easily, on the internet. And that makes it all the more important that while we are building technology, that we understand some of the potential liabilities and make sure that we have credible, trusted voices that are ensuring that people are informed.
Well, why don't you take us down that path? Let's talk for a minute about what happened in measles and your role, because there are a lot of communities. It was a very controversial time. And again, most of America, I think 92% of parents and whatnot, inoculate their kids or vaccinate their children in this. But there was an enormous controversy in the media that maybe that's not the right thing to do. So take us down that. Give us the action plan of the new Surgeon General in tackling measles.
Sure. Well, when it comes to measles, you mentioned one number which is very important, which is that 92% of kids do get the measles vaccine on time. That's very important because if you read the news coverage, if you watch it on TV, especially during the measles outbreak, sometimes you can walk away with the notion that there's a huge wave of anti-vaccination out there and that the majority of America is not getting vaccinated. And that is not the case. The norm in America is still to get vaccinated. And of the 8% of people who are not getting vaccinated, of kids, it's not because their families have deeply held anti-vaccine beliefs. It's because many of them, for example, their parents may not realize it's important. They may not have a chance to get to the doctor on time. They may not see anyone with measles in their community and think, well, maybe my kid doesn't need this. They're getting so many shots anyway. Maybe skipping this one's not so bad. There are a small minority of people in America who do have strongly held beliefs against vaccines. But one thing that we need to do is make sure that we're not only getting to them with the right message, that vaccines are both safe and effective, but we need to make sure we're engaging a variety of partners in doing that. So I'll give you some examples. You already talked about the moms collaboration that we had with Moms Rising. That was one example. I also spent a lot of time on the road going directly into communities, talking with people, doing media, et cetera, to talk directly about the vaccines and take questions. We posted on a variety of social media platforms. And what we also did is we partnered with Sesame Street and with the Daily Dot to do a video with Elmo where we talked about vaccines. And I think some of you may have seen that. If you haven't,
was Elmo a childhood friend of yours? I mean, you're very young.
Not that young, perhaps, but I was a big Sesame Street fan when I was a kid, and so it was a real pleasure and privilege to be able to team up with Elmo. But that video was very interesting to us because it was not just about reaching kids; it was about reaching their parents as well, and it was doing so through a medium, through a partnership that was somewhat unexpected, and so that was important. And in addition to getting 1.5 million or more views and being posted on many TV shows, etc., I received many calls actually and emails from people afterward who said, my kid was really scared about getting vaccines, but I showed them the video with the Surgeon General Elmo, and they felt a lot better after that, and I was able to take them to get their vaccine, and everything went okay. This is not just important for getting the measles vaccine, but because so many parents worry about the pain it's going to cause their kid, they sometimes will skip other vaccines. So reducing the concern that children and parents have about the measles vaccine actually helps them get other vaccines as well. And in fact, I think we have a short clip of the Elmo video that we did around vaccines that we could show you. The vaccine has information about germs that help your body make antibodies to fight them.
Antibodies? What's that?
Antibodies are like superheroes. They can spot the germs a mile away and kick them out before they ever make you sick.
Oh, so antibodies are the best superheroes ever.
Wow. So you were really trying to reach the kids or the parents there?
Well, we were trying to reach both, really, the kids and the parents. And what we found is that we were able to do both.
Fascinating. Whoa! Elmo, what are you doing here?
Are you okay? Hello there, Mr. Steve. You're all right? Sorry, Elmo started you there a bit. Sorry. Oh, it's so good to see you. Wait, Elmo, hi, everybody. Wait, Elmo heard that his good friend, Dr. Surgeon General Vice Admiral Vivek H. Murthy, MD, MBA, was going to be here, so Elmo wanted to say hello.
Well, hello, Elmo. It is so good to see you again. But do you remember I told you you can call me Dr. Murthy?
Oh, that's right. Yeah, sorry, Dr. Surgeon General Vice Admiral Vivek H. Murthy, MD, MBA.
Okay, great.
Elmo, we'll call you Dr. Murthy from now on.
Elmo, why are you dressed like that?
Oh, well, because Elmo is not just Elmo today. Elmo is Dr. Elmo, MD, ABC.
Wow, Elmo, so you're pretending to be a doctor?
That's right. Elmo pretended to go to medical school last week, and over the weekend, Elmo pretended to have his internship, and this morning, Elmo pretended to have his residency, and now Elmo is a fully licensed pretend doctor.
That is some very, very thorough pretending, Elmo.
Yeah, well, you should see Elmo's pretend med school bills. Yikes!
Now, Elmo, why do you like pretending to be a doctor?
Oh, well, because Dr. Elmo wants to help people. Oh, and keep them happy and healthy, too. Oh, just like Elmo's real doctor and Dr. Murthy.
Well, Elmo, that's so good to hear, because it is so important to keep people happy and healthy.
Oh, well, Dr. Elmo knows. Oh, that's why he's about to take care of his patient, Baby David.
Is baby David here for a checkup?
Oh, yes, he is, yes. And he's also here for his Vaselines.
Do you mean vaccines, Elmo?
Oh, right! Vaccines, that's right. Yeah, just like Elmo got.
Wonderful. Well, how's baby David doing?
Let's see. Baby David, how you feeling? Okay. Well, Baby David is a little afraid.
Just a little?
Yeah.
Well, why don't you let baby David know that vaccines can help keep him safe by protecting him from germs that might make him sick?
Oh, did you hear that, Baby David? What's that?
What's he saying?
Well, he wants to know if it's going to hurt.
Well, just a little bit.
Okay. Well, Baby David's maybe a little bit more worried now.
Well, maybe you can help him, Dr. Elmo. Do you remember what you did to help you not be afraid when you got your vaccine?
Oh, hey, yeah, that's right. Okay, Dr. Elmo will tell Baby David all about it. Oh, don't worry, Baby David. It'll be okay. It may hurt a little bit, but if you sing a song when you get your vaccine, it will help take your mind off of it.
Good job, Dr. Elmo. What's baby David doing now?
Let's check in and see. Yeah, Baby David. La 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 la. Oh, he's singing. Oh, good. Oh, now can Dr. Murthy help Dr. Elmo give Baby David his vaccine, please?
Well, of course, Elmo. In fact, I happen to have a vaccine right here.
How convenient, as if it were not planned.
Here you go, baby David.
Very good. He's doing very well.
He is doing great, and we are all done. Good job, baby David.
Oh, good. All done, Baby David. Oh, well, thank you so much, Dr. Murthy.
No problem. It's my job to help people stay happy and healthy.
Oh, yeah. Okay, but Elmo's gotta go. Bye.
Where are you going, Dr. Elmo?
Oh, well, Elmo wants to change outfits. Yeah, Elmo wants to dress like Dr. Murthy now.
Well, why do you want to look like me, Elmo?
Oh, because now Elmo wants to pretend to be the Surgeon General.
Oh. Well, if that's the case, Dr. Elmo, then you'll be Dr. Surgeon General Vice Admiral Elmo, MD, MBA.
Okay, you know what? Maybe just call Elmo Dr. Elmo, okay? Bye-bye, everybody!
Bye-bye, Elmo.
Bye, Elmo.
Bye! Stay healthy!
So listen, everybody, thank you so much for joining us. You're all so important to Spotlight Health. You are Spotlight Health. It's been a real privilege. And Dr. Murthy, thank you so much, Surgeon General. And let me just say and remind, as Walter Isaacson shared, that at 2 p.m. today in this tent, everyone that's attendee of Spotlight Health can join us to hear Secretary Penny Pritzker in the Greenwall tent here. And then Senator Amy Klobuchar will be in the McNulty room in Dorhosier at 3:30. So again, thank you all very much. Thank you for joining Spotlight Health.
Thanks.